All right. You can see my screen okay?
Yes.
Yes.
Do you want me to just do the first couple of slides?
Yes.
Roman?
So yes. You
Okay.
you are much more than better than Oscar. So
That's not true.
I admit, I have no problem, especially not today that my back is broken. So go ahead.
Okay. All right. Hey, so thank you all for attending. My name is Chris Prue. I don't think I've met many of you. So I'm the Director of Education. I'm based here in the United States, in New Hampshire, just north of Boston. So as Rahman said, we're going to discuss the elderly approach. And I will ask if anyone can put their sound on. There we go. So I think the first point, and I like to reiterate this with everyone, and Rahman and Oscar and Ron and I all agree that the slide representation is showing that, you know, we utilize our system through the life cycle. So starting off as children, all the way through adults and sports, and then into the elderly. And so even though that there's a particular focus here on elderly, we want to make sure that we reinforce the fact that there are, you know, a great expansion to the use of the product within the HCP's market. So we always come back and again reiterate the fact that we're able to accomplish that. So even though today we're going to focus on elderly, let's not forget that we utilize this throughout the life cycle of patients that we're actually dealing with. So in the elderly patient, and we've identified them, you know, not necessarily as a pathology, but as a group that can benefit from monitoring for health and for quality of life. And I think you'll probably hear us repeat that a lot, that when we monitor this particular population, we see they're going through a decline in their life cycle. And unlike a younger person, you know, the more that they're involved in certain pathologies and comorbidities, we want to make sure that that we try and maintain as high a quality of life as we possibly can. And actually, one of the best ways to do that is evaluating movement, is evaluating locomotion. So we do have an emphasis on falling. So when we're able to monitor, we're actually able to capture some of that information that may help us to predict whether or not someone is going to fall. I used to be a full-time professor in university, and you know, I've always told my students that were future healthcare practitioners that even if we didn't care about people, a lot of money is being spent on healthcare, and so hopefully there's a carryover, and we overlap in those two aspects in terms of the amount of money that's being spent, but also the quality of our communities, the people that we're serving. So if you look at the leading cause of death in France, it's actually falls. It's older adults, and over 200,000 per year, and that's 1,200 deaths that result from the falling. And there's a very high percentage of those people that repeat it. In other words, they had a fall, a severe fall, and they actually fall again as a result of that. And what's interesting is when you look at some of these other statistics, that 20% actually becomes a lot higher because of the percentage of people that actually do not go back into being able to walk again, to be ambulatory, that actually die. So 40% of these people don't get to go home. They're hospitalized after they've had a fall, and they don't get to go home. So that means only 60% actually get to go home, and 20% of that is a relatively high number. The longer that someone remains on the ground after falling, in other words, if they have fallen and they can't get up before someone actually helps them, the longer that they remain in contact with the ground and don't get to get up, the risk of death is exceedingly high. And so it's important that we're able to see when someone actually falls, make sure that we get them up as quickly as possible, because that's a 50% risk of death within 12 months if they're laying on the ground for at least an hour. Even in nursing homes, where otherwise it's a healthcare practitioner facility, we see still a great many of falls. And again, a lot of those falls happen during a time that they're not being monitored like they are during the day, right? So we don't have as much staff working at nighttime through the night as we see during the day. And that's one of the reasons why we see that. And there are other environmental factors associated with why we see greater night falls. But in any event, they're not detected. And as a result of those night falls, it's also being not detected is more likely that they're going to spend a longer period of time immobilized on the ground, which again, increase their risk associated with death within the first 12 months. The cost is about $2 billion a year in France, right? So that's a relatively large percentage of the gross domestic product that every country is actually paying on the healthcare of seniors, specifically related to this one component known as falling. Secondary factors associated with falls, their cognitive state, right? Their ability to have thought process and to know where they are in their environment and to have a thriving life cycle. The nutrition, so their nutritional input is very important. The types of medications we know that can have an influence on their cognition, but also on their musculoskeletal system, such as their balance. And then also their strength and activity level, their ability to keep themselves from losing balance, as well as their ability to capture themselves after they potentially fall off balance. So they lose stabilization. And we all know as younger people, we're capable of recovering from that if we are strong enough and actually if we can generate enough force quickly enough. So there's individualities when it comes to the fall factors. And like I said, those nutritional aspects, their history, their other comorbidities, right? The other problems that they have going on. In another presentation, I had shared that in Europe overall, over 67% of females, for example, have a secondary pathological condition in association with being whatever reason that they report. Uh-oh. Nope. So it looks like someone disabled me.
Yes, I think it's Rana. She kicked you out of the presentations. I don't know why.
Yes. So
sorry, Chris. I was muting wherever the sound was coming from. Not you, but by mistake, I kicked you out of the presentation. Would you please?
Like,
I think that she wants to mute you. It was a very nice way to ask you to
right, to stop talking.
Yeah.
All right.
Could you go again, please?
All right, let me try this again.
And one comment, because there is the French action plan due to the French government. However, we did a small survey in Europe, and all the Western Europe countries get that kind of program, national program, in order to decrease by 20% or something like that, the risk of failure. It's not just, the figures was just for France because we are a French company. However, in each country, it will be roughly the same. There is elderly worldwide, and of course it will be the same, roughly the same. And I'm definitely comfortable on the fact that each partners can have a look on the figures in their own country.
Right. Rana, I still can't share my screen. I'm still not considered a host. There we go. All right. Yes, as Ramon said, I mean, this is a global directive, is to reduce falls in the elderly, because as I said, in every country, it is a significant portion of healthcare being spent in otherwise a prevented type of condition. So there are many individual factors. There's also environmental factors and behavior. So in the individual, like I said, it could be related to nutrition. It could be related to their medications. In the environment, where they live. So we know that there are certain strategies that we can use to reduce the risk associated with falling, such as having high carpets, many things on the floor, the behavior. And that can also go back to the cognitive aspect of how someone behaves and whether or not that they're more willing to take chances and potentially reduce the strategies associated with reducing their risk of fall. So as Roman said, there's an anti-fall plan for elderly in France, and we have those globally in many countries that there's at least a directive, and then sometimes they also allow you to acquire certain funding, or like in our facilities and long-term care facilities, there's potential fines associated with having falls that otherwise should be prevented. So some of the consequences that we see, trauma, for example, fractures, and especially the femur fracture. So there's also a statistic then when someone falls and they fracture their femur, there's a 50 to 80% death rate within 12 months associated with that. And we see lots of fractures typically because of comorbidities such as osteoporosis, but sprains, dislocations, other musculoskeletal conditions that happen as a result of that, but then also wounds, because many of these patients may have the comorbidity of diabetes. And we know that wounds is also a big problem in the cost of delivering healthcare, but it's also the #1 reason for amputation in the lower extremity. The psychological aspect, the consequence of falling, is it creates a lot of anxiety. There's a lot of fear associated now in their mobility. And so they don't want to be as mobile. They tend to stay more stationary. And we see that has a further rapid decline in the overall thriving and the health status of the older adult patient. But the biggest one is the fear of falling. And so that reduction and limitation in wanting to be mobile has a further severe multiple consequence to what happens to their lifestyle as they move forward. Preventing falls, well, it's associated with the risks in the falling situation. So strengthening of the lower limbs. So we see that one of the reasons that they don't have the ability to recover if they do lose their balance or base of support is they don't have the strength to compensate for that. The other thing that we find that even with just basic locomotion is they don't have the capacity to be able to turn over your typical walking gait and have that balance in the stance phase. And so strengthening of the lower limbs is really important. It's also related to the balance. So strength has an indirect relation to the balance, but the coordination in the motor control system, the neurological system, highly associated with balance. And so again, related to their neurological system as well as their strength system. We do have some strategies that show that we can reduce their risk of falling by actually looking at what's going on in the feet, making sure they're wearing the appropriate shoe selection. For example, not wearing just toe slippers or clogs or things like that otherwise can come off their feet very, very quickly. And again, there's a very large percentage of these people that have the comorbidity of diabetes. And so taking care of the feet and reducing the chances of neuropathy, right? Because when they can't feel, they have no sensation in the lower extremity, they don't have the good strategies when it comes to the gait pattern. They actually start to induce overpronation, and that has a high associated risk factor associated with bad gait. And in the older adult, it's also associated with actual falls. Looking at the sources. So it could be the environment and making sure that their environment is going to be safe for them and minimize those risks such as high carpets, power cords, things that otherwise can cause them to potentially lose their balance. And what's interesting is they don't even have to necessarily come in contact, but that increased fear and anxiety also throws off their ability to maintain and stabilize their balance. Medication, real important. So in the clinical world, we call it brown bagging. A lot of these older adult patients are on so many different medications. It's real difficult to understand all of the interaction between the different medications that they're taking. And many of them can actually influence both cognition as well as balance. And so it's important to make sure that we review their medications so we do not see that sort of interaction. Vision. So vision is one of the 3 components associated with balance. And so having appropriate vision is going to be really important, and encouraging people to get their regular checkups, especially if they're diagnosed with cataracts, that it's a very simple, relatively simple procedure that can make a big difference in their ability to maintain clarity, as well as, not require as much light. So if they are walking around during some of these low light times, it's really important. So the post-fall syndrome, so that's what happens after they actually have a fall, and there's many things associated with it, and it's with the neuromusculoskeletal system, but it also includes their cognitive aspect. Again, one of the biggest results that happens from a fall is future fear of falling. And we know the statistics are highly predictive that a high percentage of those people, they are in fact going to fall again. So we see some of these differences in the relative posture positions, right? And so we see, even when we're looking at getting from a sitting position up to a standing position, in fact, in many facilities, that's a criteria for them to be able to go home after they've been hospitalized, is to be able to go from a sit to a standing position. That requires a lot of coordination, it requires balance, and it also requires strength. Other considerations are, can they actually walk? What we find is these patients have difficulty walking, and part of it is just really even their cognitive strategy, let alone what happened after the fall. If we think about when they're immobilized after a fall, if they are hospitalized, we see a dramatic decline in the functionality of these patients much more quickly than we would see in a younger person. So we need to make sure that we understand that, and all of the characteristics associated with their walking pattern, such as the walking profile, their inability to try and avoid objects. So sometimes they make reckless strategies and overcome those. We see changes in their step length, their stride length. We see changes in their trajectory patterns of their feet. They have a wider gait stance. They have longer contact times. Their speed is very slow, which also means they also have a very high cadence to try and accomplish, at least initially, to try and compensate for those changes. The neurological signs, we see a reduction in that neuromusculoskeletal system, in that their posture is going to be dramatically influenced. Another third portion to that posture is proprioception. So that's the feedback mechanisms that we have throughout the body that go back up into the brain to tell where their body is in space. And then the third one is inside of the head, the vestibulocochlear apparatus, which is where we maintain and we know that our head is in an upright posture position. So those things actually become adapted and influence their ability to maintain a normal position. It's slowed down, and as a result of that feedback mechanism slowing down, they can lose their base of support much more quickly than a younger person who does not have that. And then again, the psychological aspect is very dramatic, because typically these patients, when they fall, because so many of them are hospitalized, they often had a lot of trauma, physical trauma, and they do not want to fall again. It was a very bad experience for them. And so there's a decrease in their confidence, their self-esteem. They have, like I said, a very large fear of falling. And so they're not really motivated to do a whole lot of things as a result of that. And again, we see a dramatic decline in their overall functional status as they continue to age much more rapidly. And that's why we see these statistics, why we see this 50% death rate within a year, because it happens very dramatically and it happens very, very quickly.
Yeah, on this slide is just in terms of educations to know what to do. It's just
exactly. So I agree, and I think that, walking into a facility and showing HCPs that, you have an understanding of, well, what it means to fall, what are the strategies associated with actually getting up after a fall. And these are some of the things that you can talk to some of these folks, that you have an understanding of, how to minimize the potential for falls, but people do fall. We know that. And so are there strategies that we can use? And there are. So teaching people how to get up is really important. Remember why? Exactly. It's because if they're immobilized an hour or longer, their chances of death within 12 months increases to 50%. So getting up off the ground is really important, right? So let's look at the assessment or the risk associated with tripping or falling. We have some standardizations, and a lot of those standardizations, some use technology, but the majority of them are fairly basic, and they're screening tools that give us sort of the outcome, but they don't give us the quality of the procedure, right? So just to get up and go or a 6-minute test, we look at, a time frame, but we don't actually see the quality of their movement patterns, which, as we will see in using Digital Pro, is actually more predictive than some of the tests that we see here. We don't want to tell people that these are bad tests, but that we actually have more tests and ability to monitor these patients in a much better way, and utilizing data and reducing the time necessary to not only evaluate these patients, but we get more of an evolution. So we can see whether or not they're in the progressive stages or they're in the regressive stages of what is going on with these patients. So the two really popular ones, the timed get up and go test. So they start in the sitting position and we have them move in a very specific pattern. The 6-minute test, we also have them walk for 6 minutes. There's an algorithm. So in the 6-minute test, like the get up and go, we use the algorithm and it is age appropriate. And so the expectation is when they're younger that they should score better. But with the algorithms, it shows us that we do see this constant decline. And it's unfortunate, their predictability is pretty good. But again, it doesn't really provide us the quality of the assessment. So the 10-meter test is attempting to look a little bit more at some of their quality, and it's associated with time and speed. So one of the things that we know when we look at just the basic walking profile is their ability to move from one point to the other with a particular speed is not only indicative of a risk of falling, but it actually is also indicative of their overall quality of health. And so we're able to capture that, with an assessment system that is more than just assessing their risk profile associated with falling. But remember that all of these other comorbidities do eventually tie back into some of these problems. So the Tinetti performance test, you can see here that, there's a lot of information and it's much more qualitative. And so it takes a lot of time to be able to perform all of these tests. And some of them are still going to be important, as I mentioned earlier, looking at the sitting to standing profile to make sure that we can move into into independent living again. But so there's a balance and an assessment gait test. And again, it takes a fair bit of time, and as well as the repeatability can actually be lacking a little bit when we're working from one practitioner to another one. So basically we take a history. So if a patient actually has fallen before, remember the statistic. They are going to fall again at least 20% of the time. But again, if they're actually in the HCP's office a year after they had fallen, remember that we've lost a lot of that percentage. So that 20%, that number is going to be relatively high. We do have some basic analyses, like we said, the get up and go and the 6-minute test. And we don't want to tell people that those are bad tests, right? Because those are tests that are being highly utilized, and we do have some standardization to them. But do you know why that they're highly utilized? Is because that we haven't had the ability to use technology in the field testing, right? So we had to come up with methods that we could easily implement to provide some quality data. And it's because nobody had a gait analysis lab to look at clearance height, for example, or the strike angulation, or the other parameters that we're going to identify as being important. So the lack of precision is something that we tend to find with these field types of tests. And typically what happens is it requires a lot of extra time. People don't give the amount of information necessary that provides a good individual intervention approach to take care of the patients as is going to be most necessary. So there's a very similar treatment approach to everyone, and it's not necessarily identifying specifics as to what their problem really is. So we know that we needed some better opportunity to actually quantify this information, not in a lab setting, right? We needed to bring it to the field. We needed to bring it to the facilities where all the people are. And so having the ability to quantify all of those parameters that are determined in the lab setting to be really important. It needed to be objective, it needed to be repeatable, whether I was working with a patient and someone else was working with them on another time. We needed to remove that inter-rater reliability issue that we find in a lot of those field types of tests. Also, the ability to communicate this information. When I see those charts that I actually have to put in, and then I have to show that to a patient, they don't understand it. They don't exactly know what's going on. And a lot of these patients actually, they have a cognitive decline. And so it's much more difficult for them to actually see what's going on. The ability to perform these tests in their own environment and potentially even at their own home creates a greater environment and an opportunity to get a more true test than actually bringing them into a laboratory experience. In addition to the tests, being able to monitor all of these parameters is another key feature that as we move forward, we're going to be able to see the evolution of these situations. And as I said, whether they're in the progressive stage or in the regressive stage, can we actually monitor these conditions and can we pick up and create a prediction of a fall before the fall actually happens, right? Because that changes all of those statistics dramatically. So of all of the parameters that we have with the Digisol Pro, there are some key ones that we've identified that we actually utilize, and they're also shown in the literature to being really important as to developing this risk stratification profile. So as I mentioned, speed is a real simple one. And so we're supposed to be able to walk at a certain speed, and people that walk really slow, they do it for a reason. And it doesn't tell us exactly why, but what we do know is if they're walking slow, we need to pull some of that information out. Having a timed up and go test will only give you, well, their time. It doesn't give you all of these features. Is it maybe because of stride length? And when we look at how long their steps are, when they tend to be really, really short, that's an important amount of information that leads us to understanding why their speed is probably slowed. It also changes their cadence. Along with that stride length is also looking at the contact time and the stride duration. They tend to spend more time in contact with the ground because when they are airborne, they are not stable. They'd rather be in double support phase as long as they possibly can. So that tells us that they have a certain fear of falling and they're using strategies that are associated with potential risk of falling. The step clearance height, really important because it means if they don't be able to clear the ground, they're going to trip on that toe and eventually they're going to lose their base of support and they will fall. The propulsion ratio gives us some really cool information because that gives us some insight as to their strength and their compensatory strategies to go through the swing phase, right? Most people think of all about contact time, but every time we take a step, we're also airborne, at least on one side. So having that strategy and know as we're going into that swing phase is going to be really important. And that's where eventually we have to come in contact with the ground again. And that's the angle of attack. So we look at the propulsion ratio, we look at the angle of their propulsion, and we look at the angle of attack as they eventually heel strike. So it gives us a lot more insight than just looking at just that contact time. I'd mentioned earlier that when we look at pronation, supination, or that gait line, the trajectory in their center of mass, we find that as they start to create more pronation, it increases their risk associated with falls, as well as some other comorbidities that could be a problem. And whether or not that's the progression or that's their problem that could be leading to their fall, we're able to pick that up, not only with that single test, but let's say that those patients also have diabetes. We're able to monitor these patients. And if we see that progression into that pronation type of gait pattern during the stance phase, it also tells us there could be a progression in in their diabetic situation, and there needs to be some intervention going on, right? And maybe that's part of the co-treatment effect. As we can see here, we've got a group of studies that show the various aspects associated with what's going on during the locomotion cycle. And it's not that some of them are necessarily showing that they're not important. It also means that they just simply didn't test them. So we have a very long history in the research showing us that locomotion assessment is a really good indicator of a fall risk profile development program, right? And now we don't have to do it in a lab. We're actually able to do it while we are in their most comfortable situation, or if they're in the hospital setting, it could be an indication as to whether or not they're going to be discharged. So walking is recognized as a sixth vital sign. And so as we know that vital signs are used to collect information as to the essential body functions. And yes, we actually view locomotion as an essential body function. It's one of the things that is a major component to any rehabilitation program. If you ask a podiatrist, a physiotherapist, a chiropractor, what is your ultimate goal with your patients? It's to get them to move better. And why is that? Well, it reduces their risk associated with falls, right, in the elderly, but it's also associated with those other comorbidities. Overall, in general, you need to be able to have locomotion to have health. And so gait speed, as like we said, one of the basic parameters associated with looking at the thriving ability of an overall health aspect of an adult, is extremely important. And if that's the only thing that we were monitoring and capturing, that would be a wonderful thing. But as we have already seen, we get to capture a lot more information. But I look at, and Ramon and I have had this discussion, but gait speed to me is one of the first things. And everyone says, you know, you got to look at all the other things. I said, no, gait speed is really important. And they've outlined this real nicely to show that there's a direct relationship. There's a correlation between walking speed and its prediction to mobility. In other words, as we start to slow down, it increases our risk associated with many different things. One of them is going to be falls. Others are going to be a decrease in the cardiorespiratory system, a decrease in cognitive aspect, potential indicator of things like dementia and other neurodegenerative disorders, or other musculoskeletal conditions. And so it is a very simple metric, but again, it's real difficult to measure without using some level of technology. And so here's another, link between the morbidity and the mortality when we're looking at the walking speed. And I love this graph over here to the upper left, because it's a really decent and simple representation as to red and green, that you can easily look at your profile on your system, on your analysis, and know where they are, right? And that in and of itself is a really good prediction into the life and the health of these older adult patients, right? So we do know it's parabolic. We see that when we're young and we're learning how to walk, we don't walk as fast. And then eventually we become professionals and we're always running late and we have to get someplace as fast as possible. And then we retire and we do start to slow down. And there is a decline in both males and females with regards to how fast that they walk. But we have good data that shows that, it is fairly linear, and we do have some good predictability into looking at that. I didn't tell Ramon, but I have been teaching biomechanics, and when I used to teach gait, and we talked the reason, why you should be able to move so fast, and in certain areas of the country here, or even of the world, not everyone follows the traffic signals. In my state where I grow up, by law, if there is someone walking in the walkway, the automobiles must wait, but that is not the same everywhere. So it's real important that you be able to make it across the street before that traffic light changes and that the automobiles are able to start moving again. And so we see that having a certain level of walking speed is very important to the level of independence, but also safety, right? And so your ability to even cross the street is highly related to how fast that you can walk. And as I've said before, it's also related as how your quality of life is and your relatability to some of those other diseases. So for example, you need to walk at a certain speed. Even if you're getting your 10,000 steps in per day, it needs to be fast enough to actually create a stimulus and therefore an adaptation to the cardiorespiratory system. That's why it's important, that speed, and you walk at a certain pace to actually get the benefit from that. So there's a lot of evidence that shows that mobility is considered a biomarker. And that's why we use that term to say that walking or locomotion or gait is, a sixth vital sign. And why we want to measure that, because it gives us a lot of information into the quality of life of that particular patient, as well as their risk associated with disease. So looking at the top of the analysis system, we see that it provides symmetry, it provides speed, and it provides the cadence. Symmetry, again, a really simple statistic. We're supposed to be the same from side to side. And we've shown even in some of my studies that when we see a certain level of asymmetry, something is wrong, and it actually increases your risk of a reduction in performance, as well as increases your risk associated with injury. And that doesn't matter what age you are. So it could be an older adult or even a younger person. If you see that degree of asymmetry, there's a problem. And so we know that speed, the average adult, right, up to the age of 55 or 60 years old, should be able to walk at just over 5 kilometers an hour. Right. And that's related to their ability to maintain their overall health status. And when it's less than that, there's a reason for it. It could be because of a fear of falling. It could be all of those other parameters that we have discussed. So real simple and easy. And again, when we're talking to our healthcare practitioners, because they want to know that whatever they do, it can't take too much time. Right. And that's where a system that provides a lot of information can be challenging, but be able to bring it down to a level that it's real simple and easy to read and understand. But then there's the other part, I need to be able to show my patients so they understand, or their family members, their loved ones that are assisting them with their care. The stride length and contact time. We see that also dramatically reduced in stride length, as well as the step length, but looking at stride length. And if you look at the bottom here, that's how the system does a great job. It's just a color, right? We know that when we're in the green, it's normal. When we're in the orange, we're seeing some abnormalities. And when we're in the red, we are definitely going to be abnormal. So real simple and easy overview as to what that walking profile looks like. And to be able to explain that to patients is dramatic. The propulsion ratio, so that's something that I had mentioned a little bit earlier. So the reason I like looking at the propulsion ratio for a lot of different conditions is that's your initiation into the non-support phase, right? Everyone wants to look at just the ground contact time, but remember that with our system, we actually get some indication as to sort of that ratio or the strength and power profile of going into that swing phase, which, as we said earlier, is indicative of a potential problem. And then we look at the clearance and the steppage. So that's looking at that toe off position and looking at that heel strike position as we're going into the swing phase and how we end up from the swing phase and we land into that position. Within that same characteristic, we also see steppage, we also see the clearance, right? There should be a minimal amount of clearance, and we call that minimum toe clearance, MTC, is another important characteristic that we use as a prediction profile for your risk of falling. And we get to...
Chris, just one comment, if you can come back to the slide before that one, please. We used to say also in the French market that the stride length, to know that it's 62 centimeters, it's very easy to personalize also the protocol of care for the patient, rather than to ask him to do a very high stride length. We can personalize the care, and also the same for the next slide with the clearance and all the data. It was something, yeah.
Yes, and absolutely. And sorry, I left that out, because you can see in the pictures here, we use this information to help develop our programs, to know that it's informing, right, the intervention or the rehabilitation program to correct these deficits that we've measured. And you can see down in the lower down here in that lower to work on step clearance, right? So that's going to be working on that propulsive phase and improving the leg strength in the hip flexors. Trend stability. And this is another one. I just gave a presentation last month on balance and looking at this contact phase. So within our system, so we look at the trajectory as we go from heel strike into toe off and that relative position of the foot as we move from being in a pronated position into a supinated position in the midfoot, but as we are measuring going through pronation, supination in the rear foot, we get to see that trajectory. And that green is a real simple way of looking at what's considered to be a normal walking profile through that stance phase. And then also to remember over here on the edges, it tells us the amount of time. You don't even have to know how much time you should be spending because the system tells you that if you're in the red, it tells you that if the arrow is down, you're not spending a lot of time. If it's up, it tells us that you're spending too much time. So within this profile, it tells me that this person's actually spending a lot more time in that foot flat position. And again, that makes sense because that is where someone is most stable. They do not like to be on the heel for too long, and they do not like to be on the toe for too long because they do not have good balance. And that could be related also to their strength. And then we look at the profile here. So these dots, right? So that is where contact takes place on heel strike and then foot flat. And then we go through and then we're getting ready for toe off and so on. So these two lines on either side, that's looking at the standard deviation or the variability. And what you see here is there's hardly any variability when they're in that foot flat position. And again, that's pretty common. And one of the reasons is they've trained themselves to do a great job at maintaining that. And ironically, it's a little bit interesting in that there should be a little bit of variability. So what we find in pathologies, it can, if it's chronic, it can reduce to almost zero. But then we look at here and we see the amount of variability in heel strike and in toe off or heel lift. So they oftentimes will create some strategies. They're not really good at being on their heel or on their toe. And again, we use that information. So in my presentation, I showed on balance, I use that information to create a program, right, to assist in that process to where we can improve the strength. And I'll go back to that slide. So for example, this is a real simple exercise in the lower left-hand corner right here. This is improving the strength of the plantar flexors, right? This is where they can become stronger, and we can transition and we can do this on one foot, and we can improve this characteristic here and make them a lot more stable, as well as be able to use more propulsion in those plantar flexors to have a better propulsion rate or profile associated with that. So the biggest parameters that we find that are going to be very helpful and that you can direct your practitioners to look very quickly, and things that as we are monitoring these patients to look at the evolution of their profile, is stride length, looking at speed, contact time, cadence, double support phase, and the variability, right? All of those things, as we see those changes, as we see a shortening of the stride length, as we see them slowing down, as we see them spending more time in that foot flat position, as we see an increase in cadence with a reduction in their speed to make up for that, as we see an increase in the double support phase. Why? Because they want to spend more time with 2 feet on the ground. But then there's a lot of variability, meaning that they probably don't have good balance. So these are characteristics that all increase the risk of a fall profile. And these are characteristics that are much more quantifiable and much more quality than what we simply get from the get up and go test or the 10-minute test or excuse me, the 10 meter or the 6-minute test that are typically used. And as I mentioned earlier, we can actually look at the trajectory of these patterns to know whether or not, if they're in a rehabilitation program, are they getting better? Are we progressing in their rehabilitation program? Are we increasing their stride length? Are we decreasing their contact time, and so on? So that's from the rehabilitation perspective. If I'm monitoring these patients, I can also use it in a very similar fashion to show the opposite effect. Are they decreasing in their stride length? Are they increasing in their contact time? So the analysis allows us to look at it in two different ways to make sure that we're using the data appropriately, but both of them provide us a lot of information from not only the progressive phases of rehabilitation, but also from a monitoring phase to make sure that we can identify the risk factors associated with someone becoming a fall. So as we come back to this, and as I started off by saying, this is full circle. So we are evaluating mobility, right? Dynamic movement assessment, motion analysis through the life cycle, starting with children all the way up to the elderly. And obviously, of course, within the pathologies of everyone in between, and even in the performance aspect of sports, for example. So we've got multiple general parameters that we're able to assess. Foot kinematics, which is something that otherwise normally was required a specific laboratory experience. We're able to do this in the field. And then we've got some advanced features that you don't even see on these high-end units, which is why some of these high-end systems have to require the use of motion capture along with force platforms. We're able to capture a lot of that information simply with one device. So we're able to pick up abnormalities in their locomotion analysis that can not only be part of the remote monitoring process, but also the rehabilitation. With this, we get a comparative analysis opportunity. So I can take two different times if I'm in the rehabilitation setting and I test them at the beginning when they first come in. I retest them after we've done some interventions. I can actually make a comparative analysis and see that they're progressing or not progressing. I'm also using that to inform the intervention program. We also get to see the evolution. So I can map if I test them multiple times. And why would I do that? So classically, we may test a patient once, we see in certain markets, and then they're no longer in the clinic, or maybe we test them at the beginning and then at the very end. But why would you want to wait that long? With our system, we can actually test them multiple times because it's rapid, it's very quick, and it's very simple. So I can actually look at the evolution, the trajectory of their improvements if they're in the clinic, or from using it for a monitoring purpose, I can actually look at the trajectory of their decline if they are suspected to have a potential problem. We are a validated system against the gold standards in the industry, such as force platforms and motion capture. So we've alleviated that as a potential barrier. Because the system is really simple and easy to read and also understand, it provides a lot of information that I can then forward to my patients. When I present something to my patients and they can actually envision themselves in that situation, in other words, the data really represents how they feel and how they see themselves, that provides for a lot of excessive communication that can improve the overall compliance as well as the motivation for them to do what they're supposed to be doing, which is coming back into the clinic. But it also is a type of information that is quantitative. It's not just my opinion. And that way the patient sees that as sort of a third party as to, oh, okay, so it was a test, therefore that is really good information, is not just the opinion. Because of the usability of the system, I can easily share this information with other healthcare practitioners. They get to see exactly what I'm seeing with these patients. It assists us in working together as a team to take care of these patients, and actually shows them the quality of my type of treatment, and has resulted in improvements in referral systems because they want the best for their patients and how we can take care of them.
And if I may add one comment on this slide, it's also a fantastic tool when you are doing rehab with senior people. It's a fantastic tool to provide for the family close to the senior people, in order to make them understand that the house of the patient should be renovated for all these disorder, or he should move to a retired home or house specialized in the rehabilitations, not rehabilitation, but for the long-term care facility for senior people. So it's good for the patient, for the other HCP, but also for the family to make them understand that it's not just oral communication, it's factual quantifications and qualification of the work.
Yep, exactly. And for me, it assists in getting patients to understand that it's about function and it's not about pain. So in the elderly, we're not even really talking about pain, but it's much more about the potential of pain, right? If they do fall. But in general, all of our patients, when I can de-emphasize pain and re-emphasize the focus on performance, they're much more likely to continue care. And so our goal is to make the healthcare practitioners, you know, the expert in evaluating locomotion. And you know, me, even as a personal goal, I think we can reduce falls, which means we can reduce deaths, we can reduce expenditures of healthcare, and that's just in the elderly. But if we can improve the quality of a rehabilitation program, they're less likely to re-injure, they're less likely to come back for the same problem, which also reduce healthcare costs. It improves overall satisfaction of the patients. And for this as a vital sign, it allows me to pick up things that otherwise we may not normally see. If they came in for one condition, we're able to see some of these other problems. So
Yeah,
I'll let you go.
No. It's just because as it's our Oscar. Oscar is back.
I'm here, guys. I made a huge effort to put the camera. I'm not in the best shape due to my back, but okay. Can you share the screen? I don't see the screen. 1 second. Here?
Yeah. I'm still sharing it. Can you not see it?
No, wait 1 second.
Can you see it, Roman?
I can see it, yeah.
Oh, okay.
Oh, let me increase it. Okay, guys, so basically, I think it's just a short reminder that Digital Pro contain actually 6 pairs of smart insoles. So we have from size 36 to 47. By the way, the kids, the small sizes from 30 to 35 are going to be available very, very soon. So as you can see, the way that it's working, you have 1 pair of pods that you just use with each pair of insoles that you need in order to make the acquisition. Today, we are not using any more PodoStation, so you can use your mobile. You have your interface. The results will be on your mobile, on your interface to see it in the big screen. So it's very, very friendly user, as you already tested by yourself, you know.
Yeah, and one comment that I will be adding also, it has been South Africa partners already told us last week, like, do you have clinical based evidence that your parameters fit with the elderly? We say, no, we don't have clinical based evidence that our parameters fit with elderly. However, we have clinical based evidence that we have parameters fitting with the gold standard. That's the first point. So we fit with the gold standard in gait analysis. And second point, we have the clinical based evidence that our parameters and our acquisitions are predictable and repeatable. So with these 2 axes, we know that we can monitor someone, whatever is his conditions. We can monitor in the time the process of rehabilitations, and we can do plenty of assessment of the same person. Knowing that, we know that we can move forward elderly, sports, and also pediatrics. So that's the 2 studies that you can see at the top of the slide. It's already also available on our website. So if you want to download them, it's available. It's also available on the distributor portal. So please feel free to share and to leverage this kind of objection from your HCP.
Yeah. There's another point, Roma, that I want that we will mention here. That basically, guys, we already working in France in our local market. We are actually testing this approach. The reason that we decided now to expand and to extend internationally, it's due to the fact that we give it a try. It's working, it's successful. There are few target groups that you can approach here. Also the physiotherapists who are working with elderly people, but not only, also the residential facilities of elderly people. Roma, you want to give some additional words on this as you're handling the French market?
Yeah. So on the French market, we are finalizing, and we already are in the beta testing with a product in Orpea group, and with also Corian. So it's Orpea. It's 600,000 facility in France, and in Europe it's 1,200 facility, rehab center, but also long-term care. So right now we are handling that as a key account, moving with them, with our partners on the French market, in order to do to expand our product within all the facility. So as Oscar says, the presentations from today and the one from yesterday, it's something that we did try it. We know it's successful. That's why we come back to you saying, guys, that's how you should sell the product. That's the story that you should hammer home on your market to be very easily access to your sell and your customer.
Absolutely. So I think now it started to be more clear when we announced also in the monthly partnering meeting that now the approach of selling will be really not to make it like general, but really going in details for each and each story, for each pathology, for each target group, like here the elderly. So I think you get the first understanding the way that we are taking the sales strategy, and of course many other training will come soon.
And after that, I would like to give you back the, if you have any questions, remark, or comments on the presentations, you can raise your hand and speak up. It will be very helpful for Chris, for me, for Oscar, for Anna. In the meantime, what we have in mind, if you go visit HCP by saying, hey, I have a new product doing gait analysis, if the HCP doesn't have any interest, he will say, I don't want to listen something on Digital Pro. So don't forget it. It will be done and it will be over. Now you can go visit them. Like, okay, today I just want to exchange with you with the elderly people. How do you quantify? How do you know that at the end of the rehabilitations, your parameters or your rehabilitation has been successful and your patient is safe? And they're like, what? And now we can exchange and have other discussions rather than products. That's why we are moving in these directions. For your information, I gave a call last year to one of my friends who is physiotherapist in a hospital, and he's in a geriatric ward. And I start to exchange on the parameters, etc. And I say, Roman, are you measuring the clearance? I say, yes, I do it. He say, I have interest in your product because it's the only measurement that I can fit and to know at the end of the 2 or 3 weeks that my patient is safe. So can I have the product? So it was very like a 1 minute sales, which is much more better, much more easy for everyone. Do you have any, dear teams, do you have any questions, remark? You can, I think, activate your microphone. And if you have any questions, I will be much more happy, and Chris is here. Charles?
Romain, Oscar, Chris, Rana, I just want to thank you. I think this was a very insightful presentation. I really like the way that that you went into the intervention post application or post testing to see what we can do there. I had a demonstration this morning with with Digital Pro, and we didn't have a subject, unfortunately, but I was actually demonstrating because I've seen it before without Digital, but just doing testing on Parkinson's patients, for argument's sake, where they have support close to them and where they don't have support close to them. And as soon as they work in or walk in environments where there is something to hold on to, their gait is actually pretty normal. But as soon as you take it away and it's an open space, the gait changes completely because there's no confidence. And it was so clear to see how this would be effective. And I actually had this discussion earlier this morning. And then obviously we mentioned the different shoes, but different surfaces, from a carpet to a tile to pebbles to grass to sand, that you may be walking on, and how your gait would change, especially for the elderly, where they don't necessarily always walk on the same platforms or the same areas. So yeah, I think it was very insightful. I'm sure my whole team has enjoyed it as well. I really did, and I want to thank you for that. Thank you.
Yeah, just for your information. Thanks for your feedback in terms of neurological directions. That's for sure. We have this in mind also, to provide the same kind of message and presentation that you can do also in your market. And in parallel of that, tomorrow afternoon, for your information, we set up with Chris, someone from Denmark and Czech Republic and France. We are going to set up another kind of training like this one in a shoe selection. So we are going to set up a full protocol in order to select the right shoe, either for sports people, either for elderly, and why not in the future also for children. So it's tomorrow we will be moving on this kind of presentation and message. Another comments, remarks, question mark on the presentations in the elderly? Dorit, one row. PKL, I don't know who is PKL. But I will find. So, Chris, thanks a lot for your presentation.
We will find that it's one of our competitors.
I just would like to add that I will be sending you within the coming couple of days a link to the to a video to the video replay of this training and the training we did yesterday. Soon you will get the invitation for another training similar to this one. Please do not hesitate to share this with all your sales team, because this is really a tool for us and for you to use it with in our sales approach. Thank you, everybody. Thank you, Chris, Oman, and Oscar, and everybody.
Thank you from South Africa.
Thank you very much.
And thank you, PKL, as well.